So I have the pleasure of introducing Dr. Nisreen Rumman. And I first met Nisreen when, kind of like today, I was rushing in a little bit late and sat down to interview her. And as a pediatrician, I'm always pleased to have another pediatrician interested in our program. And I was immediately struck by the length and breadth of her accomplishments. She was born in Bethlehem. She attended medical school at the University of Baghdad before pursuing pediatric residency in Palestine. She subsequently came to the United States to do a pediatric pulmonary fellowship at Children's Hospital of Wisconsin, after which she actually returned home to the West Bank, where she worked from 2011 until starting her fellowship here. And I believe at her center, she was the only pediatric pulmonologist taking care of children with a range of complicated respiratory issues. She's been involved with multiple medical societies and task force and has a strong interest in improving care for children in the Middle East with CF and ciliary dyskinesia. She was a member of the ERS task force for nasal nitric oxide measurement in children for the diagnosis of PCD. And she is going to be starting at Washington University next year. So, Dr. Rumman, it is a pleasure to have you here today.
Thank you, Dr. Kanapari, for this introduction. So can you see my screen?
Looks perfect.
Okay, so today I'm going to talk to you about home sleep apnea testing in children. I know most of you are probably adult practicing, so it's going to be an interesting talk to listen to on the other side, on the side of children. So I don't have any disclosures. And for those of you who need CME credit, this is the number, and I think it's going to be posted in the chat as well. So the objectives of my talk today is to just have an overview of pediatric obstructive sleep apnea and the types of sleep studies that we do, and review the feasibility and validity of home sleep apnea testing in children, and review the current American Academy of Sleep Medicine recommendations, and highlight some of the advantages and disadvantages of HSAT in children. So obstructive sleep apnea is common in childhood. The prevalence ranged and varied in the literature between 0.7 to 13% according to the study. And we all know the health consequences of behavioral and neurocognitive problems, impaired growth, cardiovascular and metabolic consequences. And especially in children, we also have the social burden with disturbance in the whole family and the impact on education and psychological development. And there is a significant increase in healthcare utilization for those children who have obstructive sleep apnea. So given these detrimental effects, early diagnosis and adequate treatment are necessary. But despite this, screening of snoring in school-age children and teenagers is not done routinely. And this leads to that many remain really undiagnosed. And part of this is due to the lack of availability and accessibility and the cost of the polysomnography, which we all know is the gold standard. So we do need simpler diagnostic techniques. And just to remind ourselves that the criteria for pediatric obstructive sleep apnea diagnosis is different than adult. So according to the International Classification of Sleep Disorders, the polysomnographic criteria demonstrates an AHI of more or equal to 1, or a pattern of obstructive hypoventilation defined as at least 25% of total sleep time with hypercapnia, meaning above 50, in association with snoring, flattening of the nasal pressure waveform, or paradoxical respiratory efforts. And in 1994, the American Academy of Sleep Medicine, the Portable Monitoring Task Force, classified the sleep studies into 4 types. So level 1, which is the gold standard polysomnography, which is done usually in lab, consisting of EEG and all the other channels. So it's usually attended, and there is a possibility for intervention. And level 2 is pretty much the same as the PSG, the in-lab one, but it's unattended, and usually there is intervention is not possible. And level 3, which does not have EEG, but has the other monitoring channels, and it's usually unattended. And level 4, which is a minimum of 1 channel, so like the pulse oximetry studies. So in this talk, I'm not going to focus on level 1 because we know it's the gold standard. And I'm not going to talk about level 4 because we know that it's not adequate to diagnose obstructive sleep apnea. So I'm going to talk about level 2 and level 3, which some papers call it home polygraphy. So when we talk about home sleep studies in children, we have to ask ourselves two questions. First of all, are they feasible? Can they be done at home? And the other question, are they valid? So are they accurate? And to answer the first question, there were some feasibility studies. So this one was from 2001 from Tucson. They looked at 157 children aged between 5 to 12 who had home PSGs. So this is type 2. Technically acceptable studies were defined as more than 5 hours of interpretable respiratory channels, so airflow or either band, oximetry, and 1 EEG. And they found that 91% of the studies were technically acceptable on the first pass, and 97% were acceptable on the second pass because 9 children had to repeat the test. And the challenges they faced in that study is mostly losing the nasal pressure transducer and thermistor signal. And then this is a more recent one from Canada and Australia in 2014. They had about 200 children, the same age range, 5 to 12, who had also type 2 home PSGs. And artifact-free signals obtained for more than 75% of the recording was obtained in more than 92% of children. Exception was the nasal pressure transducer, which was satisfactory in about 67% of children. So overall, they had a success rate of 91% on the first pass and 98% on the second pass. And the challenges they faced in this study were interference from siblings during the setup, and sometimes they did not find an electricity outlet next to the bed, or the signal artifact, they had signal artifact from the laptops and other equipment at home, or the battery died when the unit got unplugged. And here also, they noticed that sometimes the caregivers did notice that there was a displaced lead, but only 1/3 attempted to replace them. So these two studies I presented were actually type 2 studies, so it included EEG. And the disadvantages here is that they are still expensive, and you still need the setup to be done by a trained staff who actually needs to travel to the patient's home. And the scoring is pretty much done the same as the in-lab PSGs because you have all the channels, including EEG, and they did not include video or CO2 monitoring, which is important in pediatric PSG scoring. So this study from Chile, they looked at 101 children, and here they compared the home sleep apnea test, which was done at home in 75 patients versus in hospital in 26 patients. And this was like the true type 3 studies, not type 2. And the ones that were done in hospital were not in the sleep lab. They did them in a regular hospital room, and the attendant was a nurse. And the age group was variable between newborn to 15 years. The setup was done by staff, even for the home studies, but they taught the caregivers how to check and replace the sensors in case they are lost. And they did provide a hotline for both the parents and the nurses for troubleshooting. And they had acceptable recording in about 93% of the studies. And actually, there was no difference in the success rate between the ones done at home versus the in-lab. However, this study from the Netherlands did not achieve that much success. It fell short of expectation. Here they had 24 children, but the difference here is that the setup was done by caregivers after careful instructions, and they only had 29% of the recordings that were successful. And they give an explanation that maybe because the setup here was done by caregivers rather than the trained staff. And some of the technical issues they had here is that children did not tolerate the sensors, and caregivers sometimes ended the recording prematurely, or they lost signals, or the bands moved, and sometimes the adapter connection got lost. So to answer the first question, are sleep studies in children, home sleep studies feasible? So based on the aggregate data from the previous studies, the HSAT may be technically feasible under controlled conditions, and we saw that the success rate was higher if the setup was done by staff, and also it was higher in older versus younger children. But the caveat here is that most of these studies had healthy children in the research setting. And the question is that if those children were to have obstructive sleep apnea, and we know they are restless sleepers, then maybe more signal loss will be from tossing and turning. So the second question that we need to ask ourselves, are the studies valid? And when we talk about validity, this means accuracy, like sensitivities and specificities, so compared to a gold standard test. So this home study versus this gold standard, excuse me, in-lab polysomnography. So this study from the ones I already presented from Tucson and from Canada and Australia did have some comparison. So in the first one, 5 children also had the in-lab studies, and there was no significant difference in RDI between the home and in-lab. And the second one had 4 children who also had, in addition to the home PSG and in-lab PSG, they slept longer at home. They had more consolidated sleep, but the respiratory parameters were also similar between in-lab and home. And so we have already 9 patients who underwent this comparison, which is not enough. So there were then 5 more studies that compared HSAT with PSG. 2 of them compared at-home HSAT to in-lab PSG, and 2 compared in-lab HSAT to in-lab PSG, and 1 just transformed the data from the in-lab PSG, and they deleted the channels to make it look like the HSAT. So let's review some of these studies. So this was one of the previous, one of the older ones from Canada in 1995. They had 21 children aged 2 to 12 referred for obstructive sleep apnea. They had 2 tests, one at home and one in lab within 1 week of each other. And here the sensitivity and specificity differed according to the cutoff of apnea-hypopnea index. So this is for cutoff 1, this is for 3, and this is for 5. And you can see that they had higher sensitivity and specificity when they use a higher cutoff value. And the sleep efficiency was greater at home with a mean difference of 5% and significant p-value. And then when they saw that these were successful, they started to incorporate home testing into their practice, and they reported on 62 more children that had only the home test with really good results, and none failed from signal loss. So this is just an example from their study for the same patient having the PSG in the first picture, and the second one is a home test, showing really the same pattern of sleep apnea. So this is a more recent study from Chicago. They had 50 children aged 2 to 14. They did home respiratory polygraphy followed by in-lab PSG plus in-lab respiratory polygraphy done simultaneously. And the setup was by a trained nurse. At the ones for home, a nurse went to the child's home, and all of the home studies were technically acceptable. But when you look at the correlation between the lab respiratory polygraphy and the home respiratory polygraphy, the lab one had better correlation with PSG than the home one. And looking at their diagnostic validity indices, they had different results. So for the same PSG index, the lab respiratory polygraphy and the home respiratory polygraphy were different or showed different results based on the different cutoff values. So giving this example on this one, the PSG obstructive RDI-3, if you take the lab respiratory polygraphy, the sensitivity was 100% if you use the 4.6 cutoff value, and it's 90% sensitivity for the home if you use 5.6 cutoff value. So this actually raises the question whether we should have different cutoff values for our criteria for the home testing. This is another study from Italy that had unattended devices done in lab. They had 12 children, 3 to 6, highly suspected to have obstructive sleep apnea. They did 2 consecutive nights of the polysomnography with this home device. And they looked at the results using different thresholds for the RDI, so 5 and 10. And you can see their sensitivity and specificity also were different based on the cutoff value of the RDI. So more than 5, more than 10, they had different results. And here with the revised RDI, meaning manual scoring, because they also did compare automated versus manual scoring, the manual scoring had better results. And also this study tended to underestimate the obstructive hypopnea, as you can see here, and overestimate the central apneas. So they concluded that this device cannot be advocated for common use in clinical setting. And this is another study that had different population, actually. In this study, they looked at obese adolescents. So they had 25 patients. They did in-lab PSG simultaneously and in-lab HSAT. And the sensitivity here had minimal variation at all levels of disease severity, but the specificity improved only at higher disease severity. And they also here had different like the auto scoring versus the manual scoring. But in contrast to the previous study, this one, there was no difference between the automated and the manual. And this is another one from Chicago. They looked at 100 children. This is the one where they actually did the in-lab PSG and then transformed the data, so deleted the channel and kept only the ones that would be available for a home study. And they also assessed the impact on clinical decision-making. So they found that the in-lab RP underestimated the AHI despite more accurate total sleep time here, because they were done in lab, so you could more accurately estimate the total sleep time. And that's because, as we know, they missed the hypopneas that were due to arousals. And actually, they noticed that the management would actually change in 23% of those children, including 27% for those with an AHI of 1 to 5 and 60% for those AHI between 5 to 10. So it does affect the clinical judgment. So in all the studies that I presented so far, only 2 of them were actually true type 3 home studies done at home. And the difference between the in-lab and the home type 3 studies is that the total recording time is usually calculated for home, but in the in-lab ones, you can more accurately estimate the total sleep time, not as accurate as when you're using EEG, but you can estimate it from the technician observation and video monitoring. And another caveat here is that some of the studies done in lab actually use the same software that they use for PSG, but they didn't have the other channels. But this software may be qualitatively different than the devices that we normally use at home. And the other difference is that, of course, having the trained staff for troubleshooting and for replacing sensors if they lose signals. So to answer the question, are home sleep studies valid? So we have limited numbers of validity studies. As you saw, some completed in lab, some at home. So really, there is no head-to-head comparison here. And there was a wide range of sensitivity and specificity that varied according to the obstructive sleep apnea severity. So based on all of this, the American Academy of Sleep Medicine issued a position statement. And in that statement, they said use of home sleep apnea test is not recommended for the diagnosis of obstructive sleep apnea in children. And some of the arguments that they mentioned is that compared to adults, partial obstruction is more common in children and O2 desaturation is less common. And also, the measurement of CO2, the use of video, and scoring arousals are important things to have for interpretation of pediatric polysomnographies. So the home studies which do not measure these may underestimate obstructive sleep apnea. And the other argument that they had is the children that were tested in these studies, most of most of them did not have comorbidities, and they did not include a very young age. And the position paper mentioned the HSAT parameters that are ideal for testing, which included ability to estimate total sleep time, so actigraphy, ability to identify the arousal, so EEG, and the other parameters, including CO2 monitoring. So pretty much like a regular PSG, but unattended at home, like a type 2 study. However, in Europe, some countries do use in-lab type 3 studies, although they are done in-lab, but they think they are easier to score and less time. And some countries like Spain, for example, they incorporated the in-lab respiratory polygraphy in their national consensus guidelines for diagnosis of pediatric OSA. And in the same country, in Spain, they actually used the respiratory polygraphy as a tool to evaluate the effectiveness of surgical treatment, so adenotonsillectomy. In this study, they had 100 children, and they did RP before and 6 to 9 months after TNA, and they showed significant improvement in all polygraphic variables after surgery, and the effectiveness of surgery was 88%. And you can see in this table that the AHI actually dropped from 11.9 to 2.6. So the position paper was in 2017. And what happened since then? And are we there yet? So many studies were published after the position paper, and some of them addressed some of the arguments in that paper, like, for example, staff setup versus caregiver, younger versus older age, and healthy children with straightforward OSA versus the ones with comorbidity. So let's review some of those studies. This was actually in the same year, in 2017, from Texas. They had 45 children, 2 to 17 years old, so included younger patients. They did in-lab PSG plus simultaneous in-lab HSAT, and then they also did at-home HSAT for 2 nights. So 4 studies. And the HSAT was technically acceptable in 94% of the in-lab setup versus 89% in the caregiver setup. And you can see in this graph that there was significant difference in the AHI in the 4 studies. So PSG versus in-lab HSAT, PSG versus home 1, and PSG versus home 2, all the p-values were significant, so they were different. And if you look at the sensitivity and specificity in their study, broken down by age, so here it included all ages, here 5 and under, here 6 and over, they are not really very perfect numbers in terms of sensitivity and specificity. The best one was probably this last one for the patient 6 and over in the second home sleep study. So again, feasible, but probably still not valid. And to address some of the questions about comorbidities, this study from Canada from 2018 included neuromuscular patients. So they had 28 children, 6 to 18. Most of them had Duchenne muscular dystrophy, and they randomized them for in-lab PSG followed by HSAT with end-tidal monitoring at home or vice versa within 2 weeks of each other. And this is the performance of their device. So at different cutoff values of AHI 1 and 5, they had different sensitivities and specificities, but still not really perfect. And because they also had measurements of CO2 levels, they found no correlation between the in-lab and home CO2 levels. So maybe not yet. Maybe we're not there yet, not able to implement this type 3 study, at least in neuromuscular disease patients. So these 2 studies looked at a different comorbidity, which is Down syndrome, and they had probably better success rates than the neuromuscular patients. So this one from 2019 from Turkey, and this one 2023 from Philadelphia. Here they had 19 children, here 40, age 6 to 18, here 6 to 25. Here they had both in-lab PSG and in-home polygraphy. Here they had both in-lab PSG and in-home level 2, so this included EEG. And they had some good sensitivity and specificity, so 100% and 83% if they used the cutoff of 3. And here they also had 81 sensitivity and specificity 75% if they use the cutoff of 5, so different cutoffs. But both studies concluded that may be feasible and reliable to detect at least moderate to severe obstructive sleep apnea in Down syndrome, and this one as well, moderate to severe obstructive sleep apnea. Maybe not the mild, but at least moderate to severe. And then comes COVID. So what happened during COVID and what have we learned from that? This is a study in 2022 from the UK. So this is a center in London, which actually before COVID, they conducted 1/3 of their studies as outpatient home studies on carefully selected children. And during the first COVID lockdown period, they completely went ambulatory. So between March and June, 3 months, they had 194 studies. 137 of them consented for this retrospective audit, and 96 patients had home respiratory polygraphy, and they were not on home mechanical ventilators, and 41 had coupled oxycapnography, which is like level 4 study with 2 channels, and these patients were on home mechanical ventilation. The overall success rate was 64%. And this graph shows like a breakdown of the underlying conditions that they have. So this is the level 4 studies. They had a success rate of 83%. And this is the home respiratory polygraphy group, underlying diseases. And they had a success rate 56%, knowing that before COVID, the actual success rate was 90%. And they explained this by the fact that the instructions before COVID were given in person, while during COVID, they were by phone. So this might have affected the success rate. And in the same paper, when they look at the outcome of home studies, I just want to focus here on the failure rate. So the highest failure rate was in the group of autism spectrum disease, ADHD, and the lowest failure rate was in patients with obstructive sleep apnea, so straightforward OSA. While in the capnography, oxycapnography group, level 4, the underlying genetic syndromes like trisomy 21 had the highest failure rate, 57%. But irrespective of the underlying cause or the underlying diagnosis, all children less than 5 years were least tolerant to the equipment. So in pediatrics, we don't just think about children, right? We also need to talk about parents. And in that UK COVID study, they did a questionnaire to assess the parents' perception. So if given the choice pre-COVID, 63% of the home polygraphy group and 85% of the oxycapnography group would have preferred the home studies. And interestingly, 74% of parents with a developmental delay who actually had the highest failure rate preferred the home study, while 53% of those with obstructive sleep apnea preferred the in-lab studies, despite that they had the highest success rate. So some more on parents' perception. A good percentage in both groups actually felt that the instructions provided were adequate. They suggested issuing like a frequently asked questions or troubleshooting guide, and a good percentage of the home studies felt that the remote signal monitoring may be beneficial, and suggested like a video call after they received the equipment instead of a phone call to go over the instructions. And 41 families felt concerned, apprehensive, or stressed about setting the equipment. And 85% of the level 4 studies felt confident due to simplicity of equipment. And based on this feedback, the center made some changes to their practice. So they added some illustrations to the instructions. They gave family links to YouTube videos, and they did video clinics with them to go over the instructions instead of just phone calls. And they started to monitor the trace remotely via a tablet by the on-call staff. And the one I presented earlier from Philadelphia also included a parents' questionnaire. And in that study, in-home HSAT was preferred to in-lab PSG in about 74% of parents. So overall, the disadvantages of type 3 studies, they underestimate the severity of OSA. And we know because we don't record arousals, we don't accurately record total sleep time. And if the child had a poor night's sleep with reduced REM, we may underestimate the events that may cluster in REM. And the technical difficulties, the poorest signal quality was mostly for the nasal cannula, and sometimes the bands moved, there was loss of adapter connection or faulty equipment. And overall, one of the main disadvantages is that there is still no perfect data on accuracy. So addressing some of the technical difficulties, let's look at what people have done to overcome some of these challenges of the home studies. So this study from Belgium, they actually had like a bi-directional audio-video communication via Skype. So they had this digital infrared camera with a speaker and microphone system, so they can actually call the patient or the parent if they lose signals and the problem may get fixed at home. So this is how they increased their success rate. And the more recent one from Australia in 2022, they had 233 home studies, and using telemedicine, connection, they had technically successful studies in 90%, and they reached an accurate diagnosis in 80% of the studies. And here, for the parents' perspective, there were good percentages of parents that perceived high-level care and increased convenience and good or excellent telehealth support. While this group from Denmark, what they did to improve their signal quality, they did more fixation of the sensors. So they taped the sensors at two sites, for example, on this, like 2 sites on the hand, and on the face, like 1, 2, and 1 at the neck. So they also made sure that each test had new batteries, so the batteries don't die on them. And they also made modifications for the nasal cannula. So the one used for adults, if you use it in children, it will go deep in the nose. And so they modified that to minimize tickling and irritation. And these are the results of their signal quality, pretty much high numbers. So 86% of the studies were interpretable in this age group, 9 to 14. So many more studies were published since 2017. I'm not going to go over them, but you can see here, like from 2019 until 2023, and these are probably not all the studies. This is by no means a systematic search. I tried to be as thorough as possible. And most of these studies were actually from Europe, maybe because Europe, they do more home studies than the US. And most of these studies reported good percentages of success rate. Here, not all of them actually looked at validity and comparing sensitivity and specificity. This area here probably represents the COVID area because they probably weren't doing as many in-lab studies. And here they had a more comparisons for validity. And there are some good numbers here, like 95% here for specificity. And here they had good results on this one. So some of them were better than the previous ones. So is it time now to review the American Academy position for the home sleep studies in children? We do have more data now, and we still don't have an update on that position paper. So I'm just going to review. I found this paper, which is really very nice. It was a pro-con written debate. So they asked 2 authors, I think one from Europe and one from the US, to give their opinion on the home sleep studies without really knowing the opinion of the other. And then they read each other's opinion and replied to that. So I tried to summarize this and kind of do some matching between the 2 opinions. So the pro says that feasibility study shows that more than 90% are technically acceptable. The con says, yes, maybe feasible, but validity is still questionable. The pro says, even if sensitivity and specificity are still not perfect, but they are more cost effective and without major health repercussions. The con says that the studies were skewed toward highly motivated families who meet strict criteria, and even with mild sleep apnea, you can still have neurocognitive and behavioral deficits in children. The pro says that wider availability of those studies means that numerous children, moderate to severe OSA, who have no access can now be diagnosed, and this can be used in resource-limited settings and reduce healthcare disparities. While the con says studies mostly involve setup by staff, sometimes on-call remote monitoring, and this questions whether there is a true economic advantage. And this technology may actually work in resource-rich settings, but this argues against a more global and equitable access. So there's still maybe increased costs, especially if you need to repeat the test. The pro says that, yes, the total sleep time is what we need for accuracy, but you can still approximate it if recorded by caregivers. So recording the wakefulness, the feeding, the sleep time. So this can be recorded. And the CO2 is not really needed in healthy children. The con says that CO2 is an important parameter, especially in comorbidities, and children are more likely to have central apneas and less likely to have desaturations. So you do need the arousals to score because of potential underscoring. The pro says that these studies are convenient, representative of the child's sleep, and they are preferred by parents. The con says safety is a major issue in pediatrics, and you do need the staff to ensure safety measures in the lab to monitor the position, to adjust equipment, and the home environment actually sometimes may be noisy by itself and crowded, and there are some caregiver limitations. But the pro says that this is the environment where the child actually resides, and this is where we want to test them, and not in the sterile lab environment. And the pro says waiting for the technically perfect study device gets us nowhere. The con says if you do home sleep studies on patients triaged as lab studies, then your payers may refuse to reimburse you. So this was a really nice pro-con argument. So in summary, HSATs in children, we are probably slowly getting there. The majority of the studies did show that they are feasible, especially if controlled conditions. The sensitivity and specificity varied according to the severity, so good for moderate to severe and less for mild. And we saw higher success rate if the setup was done by trained staff. However, there are challenges in comparing these studies. So we don't have any standardization. Most of the studies I presented used actually different parameters. So some of them, as you saw, reported the total AHI. Some of them reported the obstructive AHI. Some reported the RDI. So different parameters. So you cannot do head-to-head comparisons. And they also use different cutoff values, and sometimes the scoring criteria even differed. Some of them were scoring hypopneas as less than 50% rather than 30% reduction. And also the definition of what constitutes a technically acceptable study was different for each study. So it's hard to compare them. And then again, as we know, the setting differed, home versus lab, and the setup differed, staff versus caregiver. So also home sleep studies decrease waiting time, earlier treatment can be given to parents, to patients. So this is another advantage. And they reduce the burden to families, the cost and the inconvenience. So can be specially used in resource limited settings. But at the end, none really substitutes the in-lab PSGs, but we have promising technologies. And finally, in the last minute, I want to share with you some thoughts and questions I had while I was reviewing the topic. So should we use the same scoring criteria for home sleep studies as with standard PSGs? The other question, should we use the same reference cutoff values for home studies? There were two studies actually that looked at normal reference values for healthy children doing home studies, and they were actually different than the cutoff values we usually use. And the other question is whether combination of HSAT with other tools can increase the accuracy. So for example, combining HSAT with some of the questionnaires. There were two studies that did include questionnaires, like the OSA questionnaires, but their purpose was to assess the performance of the questionnaire versus the home study, and not really assessing the home plus the questionnaire versus the PSG. And the other question, whether combining HSAT with biomarkers would actually be more accurate. I did not find any studies that included biomarkers. And the other question, whether using the HSAT as a triage tool rather than diagnostic tool to better utilize resources, would this still be cost effective? I did not find any study that directly assessed the cost and compared between the two studies. I think they were just saying that it's cost effective based on the fact that the home studies are cheaper. But I think effectiveness studies need to include more, like how many repeats there were. Did they consider the cost of the travel of the staff to the patients' homes? So different things go into the cost. And the last idea is, how about HSAT and AI? I did find one study that used machine learning models, and in this study, the machine learning decision was better than the human decision. So maybe in the future, when machine replace us, we will get more accurate data. And with this, I will end my talk and maybe have some time for questions.
Nisreen, thank you. That is a very good overview of this. And I especially like how you got into really the fact that HSATs and polysomnograms are really sometimes kind of a apples to oranges comparison. We think of them as equivalent, but they're really, we're kind of measuring two different things. In the next 5 years, what do you think this is going to look like in the practice of pediatric sleep medicine?
So first of all, I think with the American Academy of Sleep Medicine position paper, they had ages from 0 to 18 in the same basket, right? It did not divide them into age groups. So, and we have a lot of stages, like different developmental stages, different cognitive status, different, really different physiology. So I remember seeing a patient with you in clinic who was 17 and a half year old, and we actually had to postpone his study because he couldn't come in for the lab, and we had to postpone it until he turns 18. So you can't really say 1 year old is similar to a 17-year-old. So I think in the next few years, we should have recommendations divided by different age groups, because they do differ. And the other thing I would like to see in the next few years is more freedom for the physicians to decide, really. Like sometimes it's a straightforward case that you know it's going to have a good success rate, and you cannot really let insurance dictate what we do. So I think we need to revise those studies, the position of the American Academy of Sleep Medicine.
I appreciate the optimism that the insurance is not going to be the one deciding. I have a couple more questions, but I don't know if anyone else has anything. And those of you from the adult side who lived through the somewhat abrupt HST transition about 10 years ago, if you have any insights you want to share, I'd be curious as well. I feel like part of the limitation is that there's actually some inherent limitations in the AHI and pediatrics, especially in the low range. We know that there have been good studies that showing that apnea hypopnea indices do not even necessarily correlate with neurocognitive morbidity associated with, some kids snore and you take out their tonsils and all of a sudden they're doing better in school, for example. I'm curious about some of these devices that are sort of like amped up versions of the Watch PAT that are more analogous to some of the consumer devices we're seeing right now that are providing some sleep staging that in healthy individuals seems somewhat robust. And if perhaps measures of snoring and subtle measures of sleep disruption that are not able to be picked up by the human eye might be a more meaningful measure of the burden of sleep disordered breathing.
Yeah, so actually, while I was reviewing this, I was thinking we always go back to the adult side, right, for as a reference. But in children, we probably don't need the home sleep studies to be the same as the adult one. We could still do like type 2 studies, including the EEG at home. And there were some studies that I presented that included EEG. I know the purpose is to have less work and have more cost-effective studies and have less intervention from the staff. But maybe this is not feasible in children. If we think that we do need all these parameters according to the ideal parameters set up by the American Academy of Sleep Medicine, then why not have a different setup of home sleep studies than the ones used in adults? So that's my thought. Like we could still have different home sleep studies, including EEG in the pediatric home studies.
Yeah, we're looking to get some type 2 devices, both for monitoring patients in the hospital who are on the unit, and for some home studies as well. It's potentially very helpful for our patients with mobility issues like our neuromuscular patients, though, of course, it is extra important to get good capnography as well.
And I know that the studies about that included telehealth, this probably defeats the purpose because they are still expensive and you still need to have like the same scoring. But this is another option also. I mean, nobody has really tested directly the cost comparison between those studies and the in-lab studies. So that's another option also, like telehealth.
Yeah, I don't think the cost has to be that much higher because the labs are open anyway, right? So we're open 7 nights a week. We just would have to factor in staffing.
The clinical person may actually just monitor the traces while they are on call, so they can intervene if necessary.
We have a question here from my man David de Angel Sola. Do you know of any technology being developed specifically for children? On the adult side, there's the Whisper, the Watch PAT, along with the traditional ASATs being used. It feels like we need to develop tools that are from the get-go developed for your average 8-year-old. At least that's what I hope to see in the next 5 years, rather than taking adult tools and trying to apply them to peds.
Yeah, exactly. That would be great. I mean, most of the studies I read, they did, one of them, I think it included the WatchPad, and one of them included this PM device that I presented. But many of them did not really mention which device they used, like the commercial one. They just mentioned what parameters they measured. They did not mention the name of the device. So I'm not aware if there's anything being developed specifically for children. But I do think that in the future, we have to get there because we are having a high increase in the rate of obesity in children, and we are having an increase in the patients with comorbidity, the neuromuscular patients with the new technologies and advances. So these patients are living longer and they do need annual sleep studies. And with the SMA patients, for example, we have the Spinraza, the new medication. So those patients are living now, and we're going to have a high number of required sleep studies. So we need to accommodate for this increase.
Yeah, I think if the flip side is if we can demonstrate the benefit of, say, screening healthy children as well for sleep disordered breathing or other sleep disorders in the primary care office.
Yeah, because I also have a public health background. So when I look at it from the public health standpoint, at the population level, look how many patients that are currently undiagnosed that could be diagnosed if you start using those in a wide range.
Yeah, I have some friends working at a concierge practice, and they're very interested in sort of using consumer technology to do this sort of work. I just don't think it's ready for prime time. Especially because if someone comes in and is like, my kid's REM, they put an Oura ring on their kid and they're like, my kid has less REM sleep than I'm expecting. Like, what do we do with that? We're not really equipped to deal with that, to know if it even means anything or not.
Yeah.
Or if the data is accurate.
Yeah.
But guys, if there are no other questions, this has been very interesting. Great job, Nisreen. I appreciate you. And yeah, thanks for everybody for attending on this rainy Wednesday afternoon.
Thank you, everyone.